All right, good morning, everybody. We are going to get started. I'm just saying this for video, but it is October 7th, 2021. Just some education updates from our end of the world. And thank you guys for being here on Zoom. I want to get rid of that. Video.
You just hit the camera.
I'm trying to get rid of the top thing.
They had a black and purple one. You like, I got it in the room, and like down on the bed. And
Try floating meeting controls.
And then you see the funky one, right?
Like, I don't know.
I'm not sure.
And then you have all those.
I don't know.
And then
Like, that's all
someone's
I
like,
was
well,
doing.
you can't.
And I was like, wait, you can't leave because somebody's got.
Okay, guys, we'll go ahead and get started so that way we can stay on time. Make sure you all sign in. We did bring a couple copies of the policy we're going to review today. I know it's not like the most exciting topic ever, but we and Margaret have found that we need a little cleanup on our knowledge of like just our overall standards of care and what we're doing on a day-to-day basis in the unit. So to start off, we're just going to review a little bit of policy. Hey, guys, sorry. It sounds like a really good story. I'm sorry to interrupt you, but so again, Serena did print out some copies. I know you guys aren't going to like look at it word for word, but just know that all of our policies in PACU are available on Policy Stat. And or then you can always ask us, we can print stuff off, whatever, look stuff up quick. Our charge nurses do have copies at the desk.
You guys all know how to get the policy stat from the homepage. Everybody. Yeah, if you just click on policies and then you click on policy stat, and you do have to sign in, but it's okay.
Yeah.
It doesn't do anything bad.
And if you just type in UH PACU, it'll bring up like the most 5 relevant policies to our department. And the one that we're really hitting on today is the nursing care policy, peri-anesthesia nursing standards of care policy. It's
Long, it's 8 pages. We don't have to read it all.
but obviously, so today we're just going to pull out some highlights. I think we got off of our Zoom. Oh, here we go. Okay, so overall, this is just kind of pre-op and PACU standards of care in general. So we have an initial, ongoing, and then discharge assessment. The patient is completed utilizing our ASPAN peri-anesthesia standards. Our standards of care are therefore based on the national standards. So we are one hospital that we hit home on abiding by the national standards. Not every PACU does that or has the capability, but that's one thing that we do hold strong, that like we embed that safe practice standard of care, and that's driven by like our national standards. Patient care orders are reviewed, acknowledged, and released based on the phase of care the patient is currently in. So pre-op PACU and or then PACU continued post-op. Reviewing, acknowledging, and releasing, that is our job. I know sometimes we get stuck and like it's not relevant to us or whatever, or like you don't want to release all of them or acknowledge. I think we fail on acknowledging all of our orders. But if you think back, and like this is kind of dating my nursing practice, but if you think back, like when doctors used to write their orders and you would put them on like a Cardex or like a checklist or whatever, like floor nursing, and then you would like redline it. So I know some of you haven't even been a nurse that long, but like that used to be you acknowledge that I know those tasks need to be done for that patient. This is our form of doing that now. Like we're just acknowledging that that's something we know needs to be done. And it could just be a umbrella of of like our nursing set, it gives you the opportunity to do some of those things in PACU that we know we are capable of doing, but we're at least acknowledging that we can give these medications. We can put oxygen on or whatever. So again, simply acknowledging them doesn't mean that you're responsible and that you are going to, you know, own that entire order. Does that make sense? So, and then also the importance of signing in and out of the patient chart when assuming or handover or receiving the handover of care. It will save you in certain aspects of like, if you sign in and you sign out and like something does happen, we can look back and see who really was taking care of that patient at that time, who was responsible. And then looking at a team approach, like, okay, maybe that was a new orientee that needs some more support. And by them signing in, we can acknowledge that and be like, okay, we got to touch base on this subject with that person. So it is important that we do sign in and sign out every time that you're taking care of that patient. And then the overall, so the care of the patient in our perioperative area is under the discretion of anesthesia. So they run the room. They give us the orders that are relevant here in PACU. Anything that is going to be followed up on, or anything like the x-rays, their PCA, things that are going to travel with them to the floor, that comes from surgery. I think we've got a good understanding of like who to page, when to page, whatever, but really anesthesia runs our standards of care here. Do you want to do this one?
Yeah. So there are some standards of care for pre-op. Everything that we have pulled to put on these slides comes directly from this policy here. So we're not making any of this up. But the pre-op assessment includes vital signs, and everything that you have to chart is listed in here too. Vital signs, allergies, NPO, height and weight, mobility issues, devices, sensory limitations. Definitely have to have a pain assessment while they're in pre-op. That will help us out in PACU. Verify the patient identification, expected procedure, availability of safe transport home. You have to look at skin, especially on patients coming from outside facility, and it can be a really quick turn on your side, just address, look at the skin. Especially too, if you have like a knee or a hip, you want to see if they have any open skin wound rashes on that leg. Even mosquito bites, you know, they might cancel a knee surgery for that. Have to get a glucose with type 1, type 2 diabetics. That should be in order now. Have you guys all seen the new orders? Hopefully they're showing up. And then something to think about if you have someone in end stage renal disease, think about getting a VBG for potassium, hanging 0.9, always hang your fluid orders as, you know, as they're ordered. Special considerations. If you have someone getting a block, you have to make sure, it's hard, I know it's busy and anesthesia is in and out of there, but they need to be on the monitor after a block the patient does. You have to do a Q15-minute vitals times 30 minutes. And of course, if they go to the floor, you can just, or if they go to the OR, just mark them out that they went to the OR, so you can't obviously do those vitals anymore. Hopefully you are getting a handover when the block's complete. If you're not, stop anesthesia and say, hey, what did you guys do in there? It's okay to ask them. If they're not gonna come forward with the handover, then just initiate one and start it. And then of course, we're responsible for entering those lines. So if they did like an epidural back there, you definitely wanna chart it as an LDA and ask them, ask anesthesia where. They're missing.
Is there, I guess, working in pre-op, sometimes we, you know, the patient is like whisked away and then you don't know what they did as far as a block or what the site was, whatever. But if you essentially can get the site what type of block. And then, and enter that info in the LDA. That then sets our PACU nurses up that it's already in there, because the OR nurses are not responsible of doing it. So just enter the information that about the placement. If it's placed by the surgeon or something back in the OR, the LDA should be added by the OR nurse. So it's something that they are doing back there. The OR nurses are responsible for charting that.
We're responsible for anesthesia lines in pre-op, so just try your best to make sure they're charted. Art lines are included, epidurals, peripheral IVs, nerve casts, any of that.
If they're putting them in the back, if they put them in the back, they're not in when they get.
They're not going to be in, no,
So.
'Cause they
even though
don't-
They're putting things back there, they're not responsible for entering them.
because they don't have access
So
to.
anesthesia still charts in Centricity. They don't have the access to like all the LDA.
And stuff entered, somebody has to have that.
Well, JPs are from surgery,
the-
so
OR nurses are doing that.
So the OR nurses aren't responsible for putting in the lines that are on the other lines, additional things that are
No.
entered back there that we don't see who put them in and how many attempts.
Yeah, I
You-
agree with you. Like
Yeah.
that's,
but leave that stuff blank. Like, you don't know how many posts, so leave it blank. Yeah.
if there is a line though, if they put a peripheral line in somebody's foot and you see it and it's not in your LDA, acknowledge that and put it in and say started in the OR or started by another
Present upon
provider.
arrival.
Yeah.
Things like that.
Okay.
So I know it's kind of a gray area, and I always think too, like, why am I responsible for charting somebody else's work? I get it, but at the same time, we have this caveat that like anesthesia doesn't do their charting in my chart yet. Epic. I don't know when it's gonna come, if it's ever gonna come, but so the overall picture, the OR nurses are responsible for what the surgeons do and enter in the operating room. We then pick up the slack for anesthesia and enter what they have inserted as far as lines, epidurals, A-line, whatever.
Most of it will be done if the PR nurse is doing their job.
So yes, circling back to that point. So if we can catch as much as possible in pre-op, even they're rolling off, but if you can quickly like get that in, it'll set us up better and PACU.
I think you have to remember you own that patient in pre-op. Like, just because you finished your assessment and moved on to the next patient, you still own that patient till they go back to the OR. So you need to check back in, like check your orders again, look back at that patient, see if they've had a line, because you are responsible for that patient until they go back to the OR.
I'm gonna do like a wrap up or whatever if you can. Any questions on that info? Another pre-op practice pointer. I think I sent this out. Well, it was in September. We all try to work as a team, obviously, but just remember that like IV starts, they are not to be started on like an operative site. So if I'm having a right elbow surgery or sorry, I'm pointing at my left, but whatever. I don't know, whatever. If I'm having a right-sided procedure, don't touch that arm. I know that we're limited sometimes because of fistulas and lymph node involvement or whatever. But if I'm having that extremity operated on, don't use that for a blood draw or an IV. Skin grafts, if the site is going to come from that forearm, we don't want to be poking at that arm. We want to stay away from it and use the opposite side. I know it seems simple, but these are some basic things that like we're finding that Margaret can contest it. We're getting safety reports and stuff that like little things that we just get in a hurry and you don't think about it. Or if I'm working in 1 through 3 and Monica comes along, hey, can you come do an IV for me and way? And I'm like, okay. And she's not able to tell me like, oh, by the way, avoid the right arm before I get there or whatever. And then I go to that right arm and just pop a line in. Then I then screwed her over because she's gonna get a safety report saying, hey, your IV was started in the right arm and that surgeon was hot. So communicate with your team if you guys are helping each other out with those blood draws and stuff.
He wants his IV in the same arm as they're working on that ear.
An ear,
Maybe like the.
Oh, yeah, because that's.
so
what the
they
cup
lay
On his arm.
and the cup. Okay, I was gonna say, is it positioning, but it's more.
Ideally, he would put that in.
So
special
that-
needs.
Yeah, so then again, so that's where this special needs section comes in. That's like the whole point of this. Check your special needs little section, because if it is that ear surgeon, or if it's that orthopod that only wants his lines on the operative site or whatever, like it should be listed in there. Any other specific services you guys can think about that?
You know, like the hairy necks, they have a FLAC worksheet. I don't know, like that's more at a 5:30 start, but there is,
Where do you find that?
that is under, or
Media?
media, yeah, and it's a worksheet. You print it out and put it at the bedside, and it has X off where they are not allowed lines.
It would be
So-
nice if that was printed and put on first.
Yeah, would be nice.
So if it's something like the unit clerk could scan or like, you know,
Printing like consent and all that stuff already.
yeah,
Yeah, it's for a select few procedures. I don't know, we could ask Jana, I'm not sure.
It's not for that many.
especially if it's in the morning.
Yeah, I've never seen that in all work.
Well, it's 5:30, it's usually like a
Those
5:30.
early
I've never
days.
seen
Yeah.
that.
Yeah, it's pretty,
I've never heard of the case.
yeah, but I feel like those cases start really early, like they're in the OR for
Because they're in the OR.
all day.
They have
12
Yeah,
hours.
for
or-
12 hours, so they don't generally start them
Sure.
later.
Yeah.
I think that it's something that's not being communicated by the service. Like I've noticed that more recently, that they were communicating it to us. And
Just their overall like specific needs.
there's been multiple
or-
times where that sheet's not in there. It's not just the flat sheet, it's just communicating where, you know, you'll have a case and they haven't communicated where they're taking the skin graft from.
Gotcha.
I think sometimes they don't know until the day of too, but you can always ask the patient, sometimes the patient knows.
Yeah.
Or, you know.
They should have a plan.
Because if you don't have that sheet, the patient doesn't know, and everyone's rushing you as always.
Then you just wait until that
Wait,
surgeon gets
better to
there.
wait,
You
yeah.
know, it's
Yeah.
better to be safe than that surgeon's gonna be mad that we put it in their right hands. But in essence, they should have done a better job communicating
Preparing,
and preparation.
For sure.
So.
One thing
That's
Rachel taught me is to put the special needs up at the top, so that that's the first thing you see.
I
Yeah.
agree. Yeah, this is kind of blurry, but yeah, if you move this up just right under your device or allergy, somewhere that it's gonna be like a trigger to check it. That it's a priority in your workflow that you are able to look at that. And it does always have the COVID test in there. That's where phone callers try to, you know, update that info. Put it
You
in
know,
there.
what would probably be helpful is, like which surgeries that we would be watching for the, you know, the one side. or
special
other.
stuff?
Yeah, just for like the ones that are newer.
Yeah,
Basically, ortho and the labs.
next, yeah,
Yeah,
or ENT.
Neuro doesn't have special needs. It's mostly ortho and.
Oral
Yeah,
maxillofacial,
exactly. All of that.
yeah. There's probably 3 to 4 surgeries offhand, but
What about the
Yeah.
Mohs?
most procedures,
those are, pretty-
they're pretty
Doesn't matter.
straightforward.
Site, but
Yeah.
that's any surgery, right?
Yeah.
Like, you don't put an IV wherever the surgery is.
When in doubt, you can always just,
Talk to the peeps.
yeah, just page them and ask. That way we prevent any slip ups, but again, it goes back to like, well, if you prepared a little bit more, then we wouldn't have to page you, but
Right.
okay, so then when we get into PACU, you guys know this stuff, but again, we're just trying to review and like let you guys, like, let it sink in, the charting thing that, Serena printed out has all of our required items that are required in PACU. I'm not gonna read through all of these, but, the orders themselves are to be reviewed hourly. So that's orders. That's not even your assessment, but really we should be digging in the chart to like make sure there's nothing else there. I know on the floors, what do they use? Like it's like a ding or like a notification box, like you have new orders or something else.
The brain. If you look at a little sheet, right.
Worklet icon, yeah. Obviously, we don't have that. So we just have to think like constantly like refresh your screen and go back and see if any orders have been entered. I think our department's pretty good about like, and doc, like you're communicating with them or like anesthesia, like, hey, I wrote an order for a bolus. Like you're gonna know for the most part, but just try to make it a routine. And like for those new folks, so like it is a good habit to get into every hour to check your orders.
Although yesterday in B1, somebody came in with a cooler and put it on my patient. And said, here's your blood product. And I was like, excuse me? Nobody ever communicated to me, nothing, but this patient was supposed to get plasma and platelets before procedure.
Oh, wow. Was there any
And
orders in
It was
or?
10:20 this morning and the order was placed at 9:50. And nobody said it. I'm
Yeah,
like,
so
I
you
don't
need to
even,
yell at that IR fellow and say, listen, if you want something done,
Yeah.
you better make sure, you best be calling me.
Yeah, especially blood products.
Exactly.
Yeah.
Who said, I'm like, because there was 2 units of plasma and 2 units of platelets, and I'm like, am I supposed to get all of this before the surgery? Because the orders did not specify. It just said transfuse 2 units of plasma, transfuse 2 platelets prior to liver ablation.
Wow.
And I'm like, all right. So I'm like, I don't know what it really is. So I was
So did you
like,
just,
writing a page to the doctor, and the patient was like, well, she just told me she wanted one of each. And then anesthesia came in to confirm.
I would say I would totally get a hold of anesthesia and be like, hey, how are we gonna do this? And
Yeah, I was like,
Where the IR is probably the worst.
yeah,
You're just supposed to gas it every report and all.
and don't be afraid to, page them, call them, be like, hey, like, I'm not able to just like know what you're thinking here. Like, you gotta talk and like tell me and communicate. So,
I feel like this I have a copy of.
yeah, that was the grid I'm talking about. But it does go, so as far as assessment then, in PACU, on admission, your vitals are every 15 and then, PRN. And this is our policy. And if there's ever any like question or guess or whatever, obviously, you can always refer to that. Moving into our next little update and or review. So we've had a few things going on with like peripheral nerve catheters. These are the little bags that, or I should say the catheters, whether they're in a shoulder or sometimes they come out in different sites. Yesterday, or was it, I forget which group, it was at my interns that you guys had some that were like not even attached to anything, like there was no cap even. So either the providers are getting a little sloppy with all this, or I'm not sure what's going on as far as anesthesia and APS that's inserting them. But just know that like, our portion, whether it's a peripheral nerve cath or block that they had, this is the product that we have right now. We are switching to a different product. I feel like I'm not even going to show that video.
Yeah.
Oops. Look, I got all tech savvy and I'm not even using it.
It's gonna change.
That's good.
Let me show this
One.
first, then I'll go
Oh,
back.
yeah.
So this is called Infuse Block or InfuBlock, I should say, there's a S in there. Modern post-surgical pain management. It's gonna be the same little package deal. We don't even know all the info about it. We're meeting with APS this afternoon to get knowledge, but just know like there's gonna be a little bit of a change. the key points to this though, with any of these peripheral nerve catheters, when we're hooking them up, whether it's already attached or we're waiting for pharmacy to fill it and then we have to attach it. A lot of times we fail with like unclamping the tubing and then the patient's not getting the medication. So as a visual, we're all aware that there's 2 white clamps. One's is closer to the bulb and the second one is closer to the patient. CACU RNs will be verifying and documenting that both clamps are open before they're discharged. There was a patient that went home that was clamped and then they ended up back in the ER because their pain wasn't under control, and come to find out was just that it wasn't open, wasn't even infusing at all, that local anesthetic. Documentation and the note must include obviously that they're open, and then any peripheral nerve catheter has to be added to the LDA. That is an LDA. If it's not already done so, which a lot of times they're not, back in the OR, that we have to add that to knowing that it is inserted and that we have to acknowledge that it's infusing. But again, there is a new version coming that we're going to learn a little bit more about it, and obviously we'll update you guys once we know when they're coming live to our unit. More stuff for the PACU policy. So this is just about the discharge criteria. So remember to click that the discharge criteria is met when it's applicable if there's any change in status. So even if the patient has been here for only a half hour and they're meeting discharge criteria, document it. Document their criteria is met. The policy reference of this is the peri-anesthesia nursing care standards of care. Again, patients who have met discharge criteria from phase 1 or phase 2 may require additional observation and monitoring for surgical procedure reasons. So they might be in this extended care. That's when we flip into our like floor bed weight status as well. Document the reason. Documentation will include reasons for continued PACU care, whether it's floor bed weight, a surgical assessment, kidney transplant, or they have to lay flat for a certain amount of hours. So we just need to document why they're going to continue in PACU. And our hourly assessments continue. I guess that's the whole point of this. Okay.
This is documentation for phase 2, which is on this sheet too. So you want to make sure that you get vital signs once they get to phase 2 within 30 minutes. They're documented hourly and PRN in phase 2, but hopefully you don't need hourly vital signs in phase 2.
And they're not ready.
Yeah, but if they're not ready, they shouldn't be going to phase 2 if they're not ready. So if your patient is having a lot of pain or is nauseous, things like, make sure you're doing the discharge criteria and really going through each one of those. And then of course it will still need an hourly assessment. Outpatients may be discharged from phase 2 once the criteria is met. Surgical service is responsible for the orders and completing the ABS, which I think most of the time we have all of this. The ABS is reviewed with the patient and the caregiver before they leave. And then of course you should always have your anesthesia check mark that it's okay to discharge them. Any questions about phase 2 or concerns? No?
This is just more specific about admits directly to phase 2. So they're a monitored anesthetic or a MAC sedation or those peripheral nerve blocks. We still do a physical assessment that includes those body systems. Must be observed, have 2 sets of vital signs. So they might come out and they're pretty much a walkie-talkie, but we still have to observe them, and 2 sets of vitals, 15 minutes apart, have that initial assessment. And if they're meeting criteria, they can go. The only caveats to that is gonna be your local anesthetics, like meeting those, like T12 and below, as far as like a spinal wearing off and stuff. Those people are gonna take longer and we have to observe them. But otherwise, if it's a pretty straightforward admit direct to phase 2, they're a MAC, you know, lighter sedation, whatever, they don't have to hang out. We can assess and move them along. That's pretty much summary of that.
If they come into phase 2 as a phase 1 patient, and it's MAC, you get those 2 sets of vitals. If they're staying in your phase 2 slot, you have to get that phase 2 vital signs. Does that make sense? So like once you switch from phase 1 to phase 2, like stop phase 1, start phase 2, you have to get a
I
third
think it's
one.
all the same.
Yeah.
I mean, really, because they're meeting phase 1 and phase 2 criteria at the same time, basically. As long as you like check your boxes though, like the charge, you know, phase 1 criteria met, phase 2 criteria met, really the same vitals are captured.
Just
Yeah,
want to make sure you're saying yes to they need.
that they meet it, yeah. And then extended care, again, this is word for word stuff out of the policy. So patients who have met phase 1, phase 2 discharge criteria require additional observation and monitoring for surgical or procedural reasons. Again, the kidney transplants or the spinals, the folks that have to lay flat for, you know, 4 hours or whatever, we try not to accommodate those peeps, but you know what happens. So continuous hourly ongoing discharge criteria. It's actually not required in the documentation once we've said they've met it. So same as like the floor bed weights. So once they've met it and then they move to floor bed weight, you're still going to assess them. But once that discharge criteria is met, like you don't have to keep documenting it unless there's a change. Any questions on that? Yeah, you can just move on. Don't require the hourly discharge.
Oh, my chart. Okay.
So this year we've had a couple upgrades. The next one is just in a couple weeks. It's Saturday into Sunday, October 17th. We really don't have any impact from this upgrade. Fortunately, it's not going to impact our charting in our world. It's mainly like regulatory requirements and stuff that's going to happen. But when any upgrade happens, we do have to be prepared that there's a downtime. So my chart is not going to be available. So just as a review, there are specific downtime procedures and forms that are specific for our unit. We pre-print all these and they're stored in phase 2 in one of the cabinets. If you are on call and get called in between, I'm assuming it's usually between like 2 a.m. and 4 a.m. and the MyChart system is down, we have to use a downtime form. So old school paper charting. Again, we have packets already printed, but God forbid, like we run out or you don't know where they're at, you can always go to the MyChart website and under downtime procedures, it kind of like clicks through and you just have to find the appropriate flow sheet, PACU and pre-op flow sheet for our area to be able to document. It's a mirror image of what you see in your flow sheet, only on paper. And if it's less than a half hour, we don't have to put everything back in the system. Am I saying that opposite? Or if it's more
if it's more
than a half
Someone
hour,
else
then you have to
does it.
back chart it. Yeah. Ooh, now
I don't think we do that, right? Someone else does it.
yeah, but there's a time frame and now I lost it. But in hindsight, as long as you have it charted on the paper form, we can always go back and enter it if necessary in the live version. It does eventually, yeah. I don't know who does that, like somewhere like, whether the unit clerks like say somebody does, yeah. So it's part of the medical record. Yeah. You would, like, if the patient's admitted, you would just send it with them. It's part of their actual medical record. So no, again, once the patient is discharged from that admission, then the whole chart actually gets scanned into their system, kind of like our consent forms or whatever. Everything gets scanned in as media, or so somebody can still go back and look at it. Questions on downtime stuff? Oh, here's the,
Here we go.
so it's downtime procedures, and then there's a specific pre-op record, PACU record. For physician orders, those are specific to the provider. So if it's an ortho case, if it's an opti or whatever, they have their own order sets under order sets. So we can just print that, and then you actually have to hand it to them and be like, here's what you write your orders on, because they can't physically write orders in the system either. A lot of times we have to hold their hand with that, but we work through it. Okay. Oh, I couldn't download the song, but you guys remember this song, like closing time? So yeah, it's a good. So you don't have to go home, but you can't stay here. So this is all, Shannon just announced this at the huddle, but in essence, to help optimize our staffing, especially in the evening, the charge nurses might be pulled back over here, or we don't have official charge nurse in the evening at MOD or B1, but we just need to close the unit. So I don't really want to call this a charge nurse position, because it's not. You're just going to be responsible of like shutting the room down. You're the closer. I wanted to come up with some kind of catchy name to make it positive, like, because some people get all nervous when we say, oh, you're going to be in charge after 6 p.m. or whatever. But really, you're going to work as a team and shut the unit down. There might be one patient to come, and there's 2 of you. And so some of the responsibilities we gathered from the permanent charge nurses, or those that are already doing it, of like what needs to be done. So just keeping track, ongoing bed assignments at MOD, like being in contact, like where the patient is going to help to like move them along, get them up there. And then also keeping open communication with the UH PACU charge nurse as far as staffing issues. If something changes, if it's myself and Serena over at MOT, like we're gonna have that charge nurse phone. Something changes, you know, we still need to be communicating with the PACU charge, just to make sure they're aware that, hey, you know what, we have to stay another half hour because they added on another patient or something. The other like quick duties at the end of the day, you're gonna fax the daily. So during the day, if there's schedule changes or notes that they've written on the daily, they fax it. I don't even know. I think that goes to Amanda, I believe, that's 68193. That's for like payroll reasons or whatever. The Cisco phone has to go on the charger. That's in the clean utility room. And then putting the pager away, top drawer, file cabinet. These duties will be just on a checklist, so everybody can, you know, pull the checklist out like, oh, it's been 5 months since I've closed the unit down. What do I need to do? Same type of stuff at B1. Again, we don't want this to be like a burden of like, or like give anybody anxiety, like, oh, I'm in charge or whatever. You're the closer. Work as a team. If it's just 2 of you down there, we're going to shut the unit down. Same type of duties, but just different locations. So making sure things are like closed down as far as your slots. Down in B1, so you have to lock the nutrition cabinet. I don't know. Placing bin, I'm reading backwards. Placing the bins in cabinets and lock up. putting all blood pressure cords, EKGs, ALI. So kind of like cleaning up the unit a bit. It should be ongoing, but obviously you don't want to leave the unit a disaster. Forward the pager to the main PACU and the charge nurse pager. I think that's just how to do it. Sorry, dial, and then you enter your information, and then place the Cisco phone on the charger by the quick step.
You guys are gonna be checked off on this. We're not checking you off. You'll be checked off by a charge nurse down in B1 or in Mott. So this is just kind of like an overview. We made it.
Questions, comments? There's gonna be more to come, and with like implementation of this whole like closing duties. So again, the whole point is to optimize our staff. We really want to work hard with the supervisors to try to pull people back when necessary. So we're not just wasting our bodies that are available on an offsite, that we can expedite patient care over here as well. So, questions?
Question.
Yeah.
I have a comment. Next time we do something like this, and I should have thought of this earlier, I would really like to teach people how to print patient labels and patient wrist bands. Because there's call for it a lot, and it's a very simple process, very simple. And a lot of times people will really slow down in what they're doing because they're stopping to go get a band from the clerk. And if there's no clerk in pre-op after 3, they're coming over to PACU. It just really
That's a
helps.
good idea.
I think it's a really good idea. Yeah, they were totally the Zoom people. I think that's- I don't know where it's at. I think that's a really good idea.
I try to teach
Oh, it
people
says
as
it's
we
in
go along,
progress. Oh, because you hit it. Right?
but keep going, Ted.
I think
like
you hit
it. All right,
Let's look at that in.
I just can't see the thing to oh, return to meeting. There we are. Okay. Sorry, guys. I thought we lost you. Any other questions?
Oh, should we see
Input.
if they have questions, how do we?
See if there's anything in the chat.
I guess there would be a bubble if there was, right?
Yeah.
And you guys said that these papers are at the charge nurse desk, right?
Yeah.
They're all
The policies
online.
are-
Okay. Oh, that's true.
Yeah,
Okay.
I did print 7 if you want them.